This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So the Telemedicine Assessment and Consultation team. It's kind of interesting because team-based care is very popular these days, and we're so proud that we've actually been doing it for the past 15 years. So many teams come and go, but we've really sort of stuck together. So I'm going to introduce the team members. I'm Jerry Collins-Bride, and I'm the primary care team member. We have Dr. Rowena Korobkin. She's a neurologist. Dr. Richard Goldwasser, our psychiatrist. Susan Goldwasser, who's also a psychiatrist, and Rich's wife, who is not here tonight, but she's part of our team. Jennifer Pittum, who is our TACT coordinator extraordinaire, and also a behavior specialist. And then last but not least is Alan Wong, who is our dentist. So we comprise the city team. The country team has both nurses from the regional center, a physician, regional center coordinators, nutritionist, and I believe behavior specialist. Okay. Before I get into what the TACT team actually is, I want to step back to talk a little bit about what are developmental disabilities. And this is the definition that's actually the federal definition of developmental disability. It's very similar to the one that we use here in the state of California, with the exception that the state of California has the age of origin of the disability beginning at or before age 18. The federal definition is 22. Why the age is so very important is if the disability occurs after the age of 18, it is not considered a developmental disability and indeed is not covered by regional center services. And we'll talk a little bit about the regional center in a minute. So a developmental disability is one that results in some major impairments in cognitive and or social functioning. And in addition, there must be the existence of significant limitations and 3 or more of these adaptive areas. Let's see if I can learn how to do this thing. So these adaptive areas, somewhere here. So there's got to be 3 or more of these areas that are affected: communication, learning, the ability for self-care, mobility, self-direction, capacity for independent living, and economic self-sufficiency. In general, and we see most of the clients and patients that we see have all, many, if not all of those adaptive areas that have some level of impact with the disability. Generally, a developmental disability requires a multidisciplinary approach for treatment services, and some of the more common conditions that are considered developmental disabilities are intellectual disability, which was formerly mentally retardation, cerebral palsy, epilepsy, autism, and then there's sort of a catch-all term or condition if there is a disabling condition that is closely related to the above conditions and causes similar disabilities or functional disabilities, then that might be considered a developmental disability. But I think that that one's probably a much harder sell when it comes to falling under the regional center. Sole psychiatric disabilities are not considered developmental disabilities. So a child with severe depression who does not meet these other criteria would not be considered to have a developmental disability. And we're going to take questions at the end, so write it down. We will come up as a panel and take questions if things come up. So developmental disabilities, they are really disabilities that occur oftentimes beginning with the developmental phase before the child is born, and certainly throughout the early childhood years. They're usually impairments that start, as I say, during development. They're most often expected to be permanent, and they almost always affect some combination of cognition or the ability to think, neuromuscular function, such as sensation and walking. They affect the threshold for seizures, which is oftentimes lowered, which is why you see so many individuals with developmental disabilities who have a seizure disorder. They oftentimes affect mental health, so you see many mental health conditions with individuals with developmental disabilities. And sensory processing, so issues with vision, hearing, sensation, touch, are oftentimes affected for people with developmental disabilities. So as you can see, there's many factors for an individual who has a developmental disability that are affected in terms of their ability to be able to live a good, healthy, and functional life. The challenges that they face are many. Now, the regional centers, just to kind of step into a little bit about what is a regional center, and it's kind of surprising that many healthcare providers don't know what regional centers are. And so we like to inform people about the services of regional centers, which are really crucial. They're vital for individuals with DD. So regional centers are entitlement programs in California. Not all states have regional centers. We are very blessed here, actually, to have a pretty robust regional center system. They fund services and supports for individuals with developmental disabilities, and they will serve all who meet the definition, the state definition of a developmental disability. But that does mean that you have to go through an eligibility process, and that can oftentimes be a lengthy one and sometimes a difficult one for parents or caregivers if the individual has not been deemed eligible early on in childhood. So you can go as an adult to present for an eligibility hearing, but as I say, it's a pretty exhaustive process. Regional centers will determine what services and supports are needed, and they're oftentimes based on looking at what are the goals and the assessments, the personal preferences, and of course, cost effectiveness. So it's a negotiation oftentimes with the individual, their family, their caregivers, as well as the regional center staff. Our TACT coordinator, who is also a regional center member, may come up and clarify a few more things about the regional centers.
So far, so good.
So far, so good. So the history of our project, our telemedicine project, we began in 1999, and we were funded with a grant through the University of the Pacific School of Dentistry, where Dr. Wong hails from, and the Redwood Coast Regional Center, which is the regional center that serves clients from Ukiah to Eureka. Why this project started is because I think that the regional center and the University of the Pacific were actually pretty bold in terms of looking at how could we really improve the lives of individuals with developmental disabilities. Certainly, how can we decrease the cost of services for some individuals that were very high-end users in the system? And what I think is most interesting is how can we try a different model of care that might be different from the typical, you go to see one doctor here, you go to see another doctor there, and then you travel 3 hours here. So can we look at a different model of care? The telemedicine team is based on the work of Dr. Ruth Ryan, who is a psychiatrist. She's now down in Southern California, but back in the day when we first started, she was in Colorado and New Mexico. And she had assembled this multidisciplinary team and was doing total assessments for individuals with developmental disabilities in those 2 states. And her findings were pretty remarkable. Oftentimes, clients were referred to her team because they were having severe behavioral problems or medical problems or psychiatric problems. And the amount of treatable problems that her team unearthed was pretty astounding. And I think it was sort of based on that the regional center thought that we might be able to do something better and different here in California as well. So whole person assessment really uses video conferencing to try to enhance the healthcare of individuals with complex disabilities living and working in rural California. And our mission is to understand and support people with developmental disabilities and complex needs to live productively and happily in the community, and to support the highest level of personal wellness and quality of life to each person's satisfaction. That is our mission. So this is a little map of California, and so the clients come from this part of California. It's pretty darn rural. There's not lots of big medical centers up there. There is some very good healthcare services, but there's lots of land in between them. And the population tends to be a bit on the poorer side, socioeconomically, and definitely it's a pretty spread out area. So what do we do? How do we do this? We call this a transdisciplinary record review. So our TACT coordinator compiles this huge packet of information. As a matter of fact, we're doing a TACT tomorrow morning, and maybe some of us haven't finished looking at that yet. But she puts together medical records, behavioral records, psychological records, sometimes school records, records from the day program, the school, from the family, and sends a packet to each of us to review ahead of the meeting. Sometimes we're able to see a short video clip, and it's oftentimes if somebody's having a particular behavioral issue, there may be a short video made of that we can also view either at the day of the meeting or beforehand. We get together usually on Friday morning once a month, and we do this in Mill Valley in Dr. Goldwasser's office, which fortunately has slightly better video equipment now. And for about 3 hours, we meet with the client and their support team, which may include caregivers, parents, it may include teachers. Oftentimes local healthcare providers do not attend. Regional center staff oftentimes do. And what's amazing, and you'll hear from others on the team, that we've been able to do an interview through the video with almost every client, even if they are not verbal, even if they respond in, I mean, even in looking at the records, and we thought we wouldn't be able to even talk to this person. It's been quite amazing, the response that we've had in doing this, and others will talk more about it. At the end of the meeting, we put our heads together. We come up with a lot of recommendations. And these are recommendations that are strength-based for the individual, not ones that we just want them to do a million tests, but they really try to look at what strengths the individual has and focus on improving those strengths, as well as trying to do some discovery of other problems, either mental health or physical or dental, that might be impacting them. And then Jen completes the report, which is pretty comprehensive, and she will talk about. And then also really helps with follow-up, which is absolutely key, because a big fat report that sits on a desk doesn't really help anyone. And so really making sure some of the recommendations are followed up on is pretty key, is very key. So there's our team. We have in the past had a GI specialist. I think we had a pharmacist at one point, but our core team is here and alive and well today. So that's an Old City team. Some of us are there. And that's our country team. And this is our ancient video equipment, which we now have upgraded. Hallelujah. And at this point, I'm going to hand it over to Dr. Wong, who's going to go over the benefits of our team.
Thank you, Jerry. I'm delighted to be here tonight. Let me just remind you, my name's Alan Wong. I'm a dentist by training. I'm a professor over at the University of the Pacific Arthur A. Dugoni School of Dentistry. There I teach hospital dentistry and special care dentistry. I did my advanced education in this area, and I have a passion for taking care of people with special needs. So having been part of this team has been very, very rewarding for many reasons, and I'm going to share that with you. This TACT telemedicine concept is a different paradigm altogether, and it has many benefits for the patient, it has many benefits for us as professionals, and it's very enriching. Number one thing is this is a patient-centered type of program. The focus is the consumer, and it's a very, very respectful process. As Jerry had mentioned, Jen puts together this packet of information, exhaustive and historically factual, thick record of everything you want to know about a person. And each of the members of the team review it. I don't review just my dental part. I review the neurologic, the behavioral, the psychologic. I get a sense and a feel of this person that I'm going to meet. And I get to study for it before 5 minutes of meeting them. I study it a couple of days before. When I'm there, I'm prepared. All my other colleagues, they're prepared. We're really ready to engage. So the patient that we see, our consumer, gets to be there, be present, and tell their story or share their activity one time. They don't have to tell their story multiple times. So it's very rewarding to see someone's natural reflex and reactions and expressions rather than saying the same history over and over again. To have that genuine interaction is just phenomenal. The multiple disciplines that are involved are tremendous. The resources that we talk about, psychology, nutrition, GI, psychiatry, dental, we're all looking at it from a different perspective, but all patient-centered. And from that, we get to get multiple interactions and conversations that we can ask each other. Well, what do you think about this? And everything directed toward the patient. If the information is not quite correct or seems a little fuzzy, we can correct that information right then and there with our source instead of trying to guess. It opens a lot of brainstorming options, things that we hadn't thought about just in our own worlds. And this brainstorming becomes really sort of cascading and very energetic, and I think the patient gets very much excited by it. The participants get to share ideas outside their usual areas of expertise, and in doing so, we learn something different. And then when we go to our own practices, we start thinking differently. I shudder to say that my psychiatrist colleague here knows more about dentistry now ever than before, as I start knowing a little bit more about primary care through Jerry and some behavioral through Jen. And from that, our own practices are elevated. So that's sort of a selfish reason why we get together and do this. But the overall purpose is really for the consumer in front of us. So this multidisciplinary comprehensive report that Jen puts together is a very valuable document, because nowhere in this person's life has anyone focused so much attention to this comprehensive, how can we make you better, and how can we do it the best we can, because now we have the resources of professionals, we have resources of the caregivers, of the social workers, and people that are caring for this person to, number one, make their life much better. So the other benefits of this is, overall, a significant improvement in the quality of life when the recommendations are implemented. Even some recommendations, if not all of them. And we're going to share with you some of our success stories. But by and large, we've shown very much success incrementally. The consultation by team members available to the local healthcare providers are there, and we get to learn from each other. The TACT coordinator, Jen, and the local team members ensure the follow-up recommendations. which is a wonderful component because Jen reports back to us the success stories when we have them, and there are numerous ones. By doing this, by spending this concentrated energy, you can significantly decrease the expenses and the cost of some of the health care of these individuals, these consumers, because a consumer traditionally will go from care provider to care provider, getting more medication with different side effects, but never solving the problem. And things sometimes mask one another. So no one ever stops to say, hey, what if we did something differently? Because no one gets to talk to each other in this linear progression. But when we're all together, we're able to deliberate what is the best for this patient? How can we minimize some of the medications and maximize our consumers' health? So having that discussion openly actually saves a lot of time and a lot of emergency room expenses and a lot of crisis control. So by doing this, we're going to educate not only the future physicians, dentists, but also our public by having this new model of working intraprofessionally, which is what we want to do. So it sounds like a great thing. There are some drawbacks, but minorly. So let me go over some of those. Some of the limitations, but minor limitations, are the city team is able to see and able to ask questions, but physically we can't assess the person. Fortunately, the people on the other side can do so. So we're sort of limited in terms of physical contact by just a little bit. And of course, with all technology, we also have a potential that the equipment's not quite working well. And we've had times where our equipment doesn't work as well. We can't hear them as well. We end up using a speaker phone, but we still get by because we're driven. Medical records, just like everything, sometimes have gaps in it, and that's why it's important to verify the information with the source whenever possible, but sometimes we don't get all the information we want. The downside is it would be ideal if the local care providers were also in the room with us to share with us, but sometimes they're busy on their own work, so we have to do the best we can with our collective thoughts. And occasionally we'll meet up with a little resistance from the local health care providers in implementing some of the recommendations, as some people are very, how should I say, stubborn. So for the most part, the limitations are minimal, the benefits are maximal. As I said before, it is very patient-centered, very patient-respectful, and I learned so much from it. So this has been a blessing to be part of this team. And we'll take questions a little bit later. So now we're going to go with a little history.
Hi, I'm Richard Goldwasser. I'm a psychiatrist. I actually did my training here at UCSF in both child and adolescent psychiatry as well as adult. And in over 20 years in practice, the greatest thing for me has been working with the Redwood Coast Regional Center. Just rewarding on so many levels, professionally as well as working with the individuals, the kids, the adults, the community. It's far and away the best thing, and working with the TACT team has just been a wonderful learning experience, a privilege working with such dedicated people, and I'm so grateful. In 15 years.
Yeah, we've got to change
15
that.
years. So we've seen over 100 people over the years, and with all the changes that go on in any community, we have managed to retain 5 of our original team members here in the city. And in the country team, the names that you saw up there, the nurses, the pediatrician, the nutritionist, these folks have also been constants throughout the 15 years, which has just helped facilitate the development of a real culture of commitment to taking care of folks and raising everybody's level of care, not just the folks that we see in TACT. And it's become such a part of the culture, and as Jen will talk about in a little bit, financially proven to be such a beneficial service that it now is budgeted in as part of the annual Redwood Coast Regional Center purchase of services. So in terms of accomplishments, what have we done over the years? The kind of holistic approach that you've heard about has enabled us to better identify not just the obvious conditions that somebody may be presenting with, but also comorbidities. Comorbidity is a term which refers to the occurrence of more than just one condition at a time. Most of the folks that we see at TACT, and frankly, even outside of TACT, have multiple issues going on. Somebody may have the epilepsy, but also have intellectual disability, significant problems with mood or behavioral disturbances. Folks may present with underlying medical problems or dental problems, especially dental, tooth pain, cavities, dry mouth, or gastrointestinal problems, constipation, incredibly common problem. But for somebody who's not able to communicate reliably if they're in pain and they got a horrible toothache, or they're horribly constipated and have a painful bowel movement every 3, 4, 5 days, what you may end up seeing instead are behavioral problems, intense mood swings, aggressive or self-injurious behaviors. So part of the process that we go through is teasing out not just what's obvious, but what are the other comorbid conditions that are present that may be actually driving the problem behaviors that prompt the referral. The net result then of this multidisciplinary approach is being able to look at somebody and say, okay, for example, we have a number of things here that are being treated with 3, 4, 5, 6, sometimes a dozen medications. First thing we're seeing tomorrow has 2 pages of medications that they're taking. Not unusual for the people that get referred. 2 or 3 antipsychotic medications, multiple anti-epileptic medications, a ton of GI medications thrown in there, a whole slew of stuff with drug interactions, secondary side effects from each of those medications. Part of our goal is to use medications as judiciously as possible. So if somebody has, for example, high blood pressure and is also very impulsive, rather than having 1 or 2 different type of blood pressure medications and an ADHD medication or an antipsychotic medication or a mood stabilizer, we may say, well, what about one of the blood pressure medications, the alpha-2 agonist, that can help with hypertension and with impulse control? Getting rid of 2 or 3 or something even more medications by using something that has multiple end results. Similarly, people that we've seen have had epilepsy as well as bipolar disorder, or bipolar spectrum disorders. And rather than having 2 or 3 different medications for the epilepsy and the bipolar disorder, or the aggression, the self-injurious behaviors, maybe a couple well-selected anti-epileptic medications would get just as much benefit without the other side effects and the drug interactions. And so that's kind of what Alan was talking about, the beauty of everybody being in the same room at the same time, that we can talk. Yeah, Rowena, what about such and such? Well, that might not be so good, but how about, well, what about Lamictal? Okay, well, yeah, Lamictal, great idea, or Depakote. So that kind of in-the-moment brainstorming enables us to make recommendations to the country team on reducing the amount of medications and ultimately minimizing the amount of side effects that somebody has to be living with. The ongoing interdisciplinary learning, huge. By working with this team, my practice, and I think I can speak for everybody else, has also been impacted. Everybody that walks in the door from typically developing kids to adults, I'm asking about their teeth. I'm asking about their bowel movements. Stuff that when I finished training wasn't even remotely on my radar. And it's astounding how many people have these other issues that, as I've learned from my colleagues here, impact daily functioning. And now, at least I have enough experience to be able to say, okay, here's some things that I've seen pediatric gastroenterologists use to help manage constipation. Here's some things that we might look at doing. And also, as part of the bigger picture, what kind of things are important with basic health maintenance? So asking about immunizations. If kid isn't up to date with immunizations, making sure that that's one of the recommendations. Standard screening, for people who are in their 50s, 60s, making sure that they're getting the same kind of standard of care that typically developing individuals come to expect from our primary care providers. Because there is a tendency, particularly with the developmental disability community, to sort of put off, mammography, that's going to be too hard. A person's not going to be able to cooperate with the colonoscopy. They don't really need to have a dental exam on a regular basis. You can do it every several years, or if there's a real problem. It's like, no, that doesn't work. That's not good enough. So the interdisciplinary learning improves the quality of care for the individuals that we see in TACT, but also in our broader practices. So what are some examples of things that we've been able to do? Certainly reducing seizures, reducing tics in individuals through more judicious use of medication. Weight loss, huge issues. So many of the medications that are used for in psychiatry, as well as in other fields of medicine, have weight gain as a problem. And again, there's this sort of tendency to be complacent about, at least the person isn't breaking things, isn't aggressive. We can live with the weight gain and the constipation and the dry mouth. Having weight loss as a goal, along with the behavior and the mood stabilization, that's been really big in enhancing the quality of life, reducing orthopedic problems, reducing the risk of diabetes, for which many of these people are at higher risk because of taking the antipsychotic medications, and on and on and on. Of course, less aggression, that's a common reason people get referred to the TACT team because of aggressive behaviors. When somebody is able to be helped in a way that reduces the sort of intensity of services that are required, the need for out-of-home placement or the need for placement in a facility, that is eliminated. And Jennifer will give some examples about that. Improvements in speech and communication, always a big issue, rapidly evolving in the last 5-10 years with the electronics, but also with more intensive speech and language therapies for kids, and even with adults who are nonverbal, being able to use pictures as a way of communicating, working with behaviorists, which as we were driving in, Jennifer was telling me that many of the regional centers in the state still don't believe in using behavioral consultation for adults. With Redwood Coast, this is like part of the fabric. Increased mobility and activity, of course, lose weight, not in pain, mobility improves, and then increased coordination of care and supports. This has been one of the other things that I found very rewarding over the years, is developing relationships with the pediatricians, with the primary care docs, with the nurse practitioners, with the PAs, with the therapists, in Lake County, Mendocino County, Humboldt County, all the way up to Del Norte County on the Oregon border. Throughout all of those areas over time, as we've collaborated with over many of these folks, the level of comfort that those docs and those primary care docs and those therapists have had in recognizing and treating mental health issues has gone up. In the past, anything beyond ADHD, it's like, forget it, I can't do it. Now, when Ted Humphrey calls me to asking about seeing a kid, it's like, I know that kid has gone through a lot of different stuff and is a really complicated one. And that sort of level of sophistication has really risen, not just with that pediatrician, but with a whole slew of providers in the Redwood Coast catchment area as an added bonus of the whole TACT process.
Hi, I'm Rowena Korobkin. I'm the neurologist on the team, and my background is actually pediatric neurology, but I've learned to understand a lot of things about adults, especially some of the ongoing health needs that are so different from child general health needs that a few years after working with the TACT group, I became the neurologist consultant at Sonoma Development Center, which is all adult, and put a lot of the things I've learned from TACT to use there, where we do, believe it or not, function as a team these days. Anyway, that's part of what has happened by doing this as a collaborative group. One of the things that I think hasn't been mentioned enough is that when we get together in these 3-hour sessions with the client on the other side of the TV screen, and the client's care providers there on a TV screen, and we're sitting and they're seeing us on our TV screen in Mill Valley, is that any one of us could be asking questions and thinking about issues for that particular client. Again, it's so client-centered, that are issues not having anything to do with our particular expertise. Sometimes Jen who is not a physician, will ask medical questions and have good ideas about something that strikes her when she's hearing about a particular problem with a client. And so all of that is really important to make a true interdisciplinary team, and we all learn from one another. And it isn't just that I know something about epilepsy that nobody else knows. Sometimes I know a little bit about a drug that is a little bit esoteric and nobody else knows about it. But over the years, we all know something about everything, and with these clients, and put it to use and feel perfectly fine about making a suggestion that's different, that's not part of our expertise. The way the system actually works when the client is on the TV screen is we actually take our microphone and go around the room, one person at a time, asking questions and trying to clarify some of the issues that we know are issues for that person, because we read all of the background information and have some idea of why it is that they've actually come to this session. What are some of the complex problems that we should be addressing? So each one of us has a chance to ask questions about what's happening in that person's life, and may be able to get enough information to make things a little bit better and come with new suggestions. So it does change the practice parameters, the overall paradigm, and as we've said, decreases community barriers because of the relationships that we've built. Another reason that this has been so successful and continues to be more successful is, again, what Rich said, is over the years, we have built relationships with people through that whole catchment area so that there's a level of trust. And that's something I've seen at Sonoma Development Center as well, that at first, when I said, you know, you've got to get rid of the phenobarbital, you've got to get rid of the dilantin, you've got to get rid of the carbamazepine, you've got to do this, you've got to change that, people are aghast. Well, if we do that, everything's going to get worse. The person is going to go into status epilepticus. They'll end up in the hospital. Work will be harder for us. We can't make any drastic changes. But over the years, when people realize that you're a reasonable person and that we're all reasonable people trying to improve quality of life of these individuals, we're not just trying to improve quality of life of the care providers, which we do try to do, but it's also improving quality of life. And those two things may be in conflict of the client. And so we manage somehow making things better overall, I think. All right, well, here it is, cost benefit. It's pretty amazing to realize that at first we thought, well, this is going to be so outrageously expensive to have all these professionals. Each one of us gets paid per hour for the hours that we spend with one client. I mean, here we are sitting there on Friday morning from 9 a.m. till noon with one patient. You know, in today's era, look at Kaiser, your primary care physician gets maybe 15 minutes for an annual exam, but it's probably less than that. So how many, in order to have cost benefit, they're saying you have to see X number of people in a working day, and we're saying we're going to have all of these professionals spend 3 hours focusing on one client. And in addition, we've spent several hours reviewing the background information about that client. And so when we first started this, I thought, this is going to be crazy. How is anybody going to continue to pay for this? It was a research grant, so we knew it would go for a year or two, but the idea that it would go beyond this grant was amazing to me. And then the regional center found out that it is really cost effective because several of these clients were in such crisis with multiple medical, behavioral, other problems that the home that they were living in couldn't take them anymore. They had to move out and were going to be put in a crisis home. Well, a crisis home is $198,000 a year. If you get placed into Sonoma Development Center, you're up to $407,000 a year, which is why all of the development centers in California will be gone probably in the next 4 or 5 years. We're down to something like a total in the whole state of California of about 1,200 or 1,300 clients living in development centers from not that long ago where there were many, many thousands. And people that are in the college, is it college or cottage?
Hospital.
College hospital.
It's a private hospital in Los Angeles
Yeah.
that sort of will take as last resort.
Mm-hmm. Right. And that's even more expensive than the development center. So all of a sudden, a TACT session that costs $5,000 and has other services up to $5,000. So all of a sudden, $10,000 seems very low if you're going to prevent any of those other things from happening, and we do. Not only do we prevent that, but we're preventing many emergency room visits and a couple of emergency room visits, and we've covered all of that expense for sure. And I know, based on some of our follow-up, that many of our clients have had major reduction in emergency visits. Well, there it is, the reduced emergency visits. Decreased medication costs. One of the things that we've found over and over again is that people, especially for behavior and also for epilepsy, people get placed on initial medications for whatever behavior and whatever seizures that the client's having. And then, when that's not working, another medication is added, but they never, in the community, never remove the first one that wasn't working. They just add the second one, and then they add the third and the fourth, and never consider that it might be more beneficial to cut some of the ones that didn't work in the first place. And these medications are expensive. Psychiatric medications will cost typically in the range of a couple of $1,000s a month just for the medication for outpatient for severe psychiatric illnesses, bipolar disorders, schizophrenia, et cetera. And potential decrease in service needs because things have been uncovered that straighten out a lot of health and contributing problems. So I think that's the end of what I have to say.
Okay, so my name is Jennifer Pittam, and I'm the TACT coordinator. I originally started on the team as a behaviorist, and then we went through a couple of coordinators, and I added a hat. Didn't decrease a hat, but did add one. In terms of what we've discussed so far, it's lots of medical stuff, which is inherent. They're the doctors on the team. But we really do focus on the whole picture in the person's life. We have sometimes advised that all these other changes can happen, but really the first thing that needs to happen is they need to move. They have a landlord who's mistreating them, who's violating their rights, and of course they're angry. That needs to happen before we do anything else and look at anything else. We have, looking at the school program, looking at communication, looking at all those other things, in addition to all the medical pieces. Because we've been doing this, and it was touched on briefly, for now 15 years, actually I think we're hitting 16 this month, but we kind of lose track, it's been a while. We actually, not only the medical professionals within Redwood Coast Regional Center, but also the service providers and the staff at the regional center have gotten good at asking a lot of the questions we ask. And whereas we used to get referrals to TACT, and it was like, well, they haven't seen a doctor in 4 years, and yeah, we tried this program, and they kind of have this little star system. Now people are getting much more creative and trying many more things and thinking more broadly before they ever come to TACT, which is a double-edged thing for us, because it means when they come to TACT now, they've really tried all that, and we're really, having to come up with really creative answers. So I want to give a couple examples of folks who have come through TACT. The first one is Sally. Sally was 9 years old, and these are all, made-up names. Sally was 9 years old with autism. She lived in one of our coastal communities. She had cyclic vomiting for 3 to 4 days in a row, and I mean continually for the 3 to 4 days, 2 or 3 times per month. She wouldn't sleep. During that time, she was aggressive to the point of sending family members to the ER for treatment. And this is a 9-year-old. She was scheduled to move into one of our crisis homes. I mean, her name was already posted on calendars on the wall. I mean, that's how scheduled she was to move in. She had a very limited diet by her choice. She could read and use the computer, but she didn't have a whole lot of speech. We talked about this, and Rowena goes, I think she has abdominal migraines. And most of us looked at her and go, abdominal what? Never heard of it. So we recommended that they try Zofran and Imitrex. And the family was really resistant to meds. They didn't want to put her on a bunch of pills and things that were going to be every day. One of the things, Imitrex is a nasal spray, so they could get it even when she was vomiting. The first time they tried it, the cycle stopped with the first dose. So she had the first episode of vomiting, they tried it, it stopped. And that usually is what happens. I mean, they usually can't predict it far enough ahead to get it before the first round, but that's significantly better than 3 to 4 days. With the decrease in that, the aggression has disappeared. Her family decided she didn't need to go to the crisis home. She got to stay with her family, which also saved the regional center at least $180,000. So that paid for a lot of future TACT sessions. Because she wasn't sick so much, she got to attend school. The TACT team figured out that somebody who can go through their computer with over 1,000 songs in their iTunes library and could find the right song no matter if they were picking artist, album, song, et cetera, whichever preference, and could find it, that's reading. That's not you have it memorized, because the order changes every time you do that. She could still find it. We convinced the school of that. They then brought in a communication specialist and got her a computer and a communication system. Her diet's still restricted, but she's gradually adding things to that. Medical workups for other issues were negative. It appeared that actually the main thing was abdominal migraines that nobody had diagnosed. So that was Sally, which has been a huge improvement in her life and a huge improvement in her family's life. And Sally is now 16, and things are still overall going really, really well for Sally. So we're really happy with that one. Mike, talked about ER visits. Mike was known in the town that he lived in as the $10 million man, because that was his annual ER visit cost, including all the tests and the ambulance visits, trips, and the medications and everything else going on. And that was between 2 hospitals. When we asked for his medical records, it was literally 3 feet high. That was 1 year. The team did not get a 3-foot file. As much as they complain about thick files, I actually did wade through that and just pull the highlights. He also had multiple arrests per year for intoxication. Chronic use of alcohol, just horrendous amounts of alcohol, and sometimes painkillers. The ER basically, by the time this had been going on for a couple years, was pretty much he's drug seeking, that's it. We just want him out, standard get out of my ER, we don't want to see you. He was avoiding staff. He was actually running away from the staff who were trying to support him. He had bulimia. He binge and purge right and left. And he refused to take any medication on a regular basis. The TACT team, in hearing all this and talking with him, and he's quite articulate. I mean, he spent almost all the 3 hours having very complex and interesting conversations with us on a variety of topics. We didn't totally buy the drug seeking. There was something else going on. There was that intuition to it. And we said, why don't we just try having one of his staff, like hire a CNA, have her come in the nurse's uniform, and have her do all of that. So they did. That was no cost to anybody. That staff was going to be hired anyway. CNAs get paid about the same as direct care staff, no cost. But they went to his house twice a week in their nurse's uniform with their stethoscope, all that stuff. And it worked really well, and I'll get to that in one sec. We also worked on acceptance of support, or we recommended getting a conservatorship or 6500 order, which is a court order that they have to comply with services and live in a certain place as determined by the court in the regional center. We suggested adding behavioral services. We'd like him to decrease his alcohol and drug use, obviously, and increase his compliance with medication. There was a lot of resistance to getting any kind of court involvement in terms of conservatorship or other court orders, and that never did happen. We did get behavior services. When we added the CNA, in the course of over a year, his ER visits stopped. He went twice, and that was when staff took him because it was truly necessary. One of those, I know he loves sewing, and one of those he happened to fall asleep and somehow managed to get the needle jammed completely in his arm. That's legitimate ER visit. But the ER visit stopped. So what does that tell you about he was drug seeking? It wasn't. Having someone come to your house in a nurse's uniform is not an equivalent of getting drugs. It is an equivalent of getting attention and social and all those pieces. That's what he was after. We added the behavior services. He was still drinking. At the time, he actually has now stopped drinking, which is amazing. With not going to the ER for all those visits, the doctors actually started taking the complaints he had seriously, because it wasn't just, oh, he's just drug seeking, get out of here. It was like, wow, maybe there really is something wrong. He's only been here twice. And he's been to the regular doctor a couple times. Found out that, in fact, he had some legitimate pain issues, has some legitimate pain management now. And that actually has, we think, contributed to the basically stopping of the alcohol use. At the 8-month mark, he was still having a few arrests, but it was lower than it had been. And at this point, he's not been arrested in over a year. So it's all been really good. And again, there was no cost to any of this except the behavior services a little bit. It had to do with restructuring some of his life, and then we could put in the other pieces and try and get the behavior piece and do some things. And this is actually one of the ones that I look at, and I see him in town because we live in the same community, and it's just amazing. He has his own apartment. He has part-time staff who support him with cooking and meals and different things. Eating's still a bit of an issue, and he still does struggle a little bit with bulimia, but he's working on that. But this is about 2 years ago we saw him, so it's pretty major transformation. Matt, this is a real name. We have permission to use Matt's name and video and pictures, et cetera. Matt has presented with us at the UCSF Medical Conference that happens in March every year. If I can do this without crying, I'm always so amazed at Matt. Matt was literally dying when he came to TACT. I mean, we all are pretty much in agreement on that. He was severely declining in motor skills. He had gone from somebody who was running around and happy and talking to he was literally no longer walking. He had difficulty swallowing. He had pneumonia 5 or 6 times in 1 year. He almost died several times in the hospital. The motor skills were declining to the point where everyone was convinced that if something major didn't happen, he probably had a year or 2 to live. If it was going to continue going downhill, and we didn't know, I mean, maybe it was something that was going to continue going downhill, but it was hoped we could figure this out. He had meltdowns in terms of behavioral issues. He would just lose it. His dad is like 6'3", give or take, was a bull rider as a professional for years and years and years. Matt could drop him to the ground with one hit, okay? And he just wasn't happy. So, and there was significant family stress, needless to say, with all of this. Okay, so this is a video of Matt before when he came to TACT.
It's okay, Tape. It's okay. Ready to go.
Oh, that Cannon?
Tape, it's okay.
Sally.
Good job.
Cannon?
Look at those big steps. Come on. Show me your big steps. Show me your big steps.
Go, Matt, go.
Is that your big steps? Come on.
No thing.
No, tape is okay. Just so they can see how you walk. Okay?
See Mike?
Let's see Mike. That's right. Okay, turn and go back the other way. Go for your chair. Okay, ready? Here we go. Come on, show me your walk.
Okay.
Big steps, man. Big steps.
And again, this is a gentleman who used to run around and go feed the horses and climb all over their property and do all these things.
Go.
This was serious.
Those are nice steps. Those are good job. Oh, whoa, look at you go.
Okay. It's kind of just more of the same. Before TACT, people had changed his meds, pretty much added meds in some cases. He'd been seen by his primary care. He'd been seen here at UCSF in orthopedics. He'd been seen by neurology. He'd have behavior strategies. We had tried all kinds of things with Matt. His medications at the time of TACT, he was taking 25 milligrams of Abilify, 2 of Risperdal, 5 of Lexapro, 4 of benztropine to counteract the effects of the first 3, 4,000 milligrams a day of Depakote, 300 of Luvox and Amantadine. We suggested that maybe he was on too many meds. We had a plan of how maybe to decrease those. We suggested a swallow study, formal behavioral services again, work on some dental concerns. Matt grinds his teeth like crazy. Increase liquids, increase social relationships for Matt. I type up all the reports, as you've heard. All these recommendations were in there. They were given to Matt's doctor and his psychiatrist. And his psychiatrist and doctor got together and concluded that we were insane. And his doctors talked about this publicly. So I'm not going to give his name, but he has shared that he and the psychiatrist both thought we were all nuts, that we didn't know what we were doing, we were completely crazy. But they were going to humor us and go ahead and try it. So they decreased the meds, and Matt started at least not declining anymore. Then they decreased some more meds, and Matt started actually improving. And then they decreased some more meds, and Matt's now out of the wheelchair. He's now walking readily. If his dad can't park, half a mile from our regional center for some reason, or they're having lunch first, he'll walk the half mile with his dad with not having to hold on to anybody. He actually runs. Again, in fact, he ran into the street a couple times, which wasn't great, but he could run into the street. That was good. We've added the behavior services. We're still working on swallowing and aspiration. Matt, that seemed to actually not get any better when the meds changed. Matt actually wound up getting a G-tube, which he actually he likes that he isn't choking anymore. He was clear that he was having trouble with choking. He got to where he didn't want to eat because he knew it was going to choke, and then he knew he'd be in the hospital. And he actually talked about, I'm going to die. So the G-tube has been a little bit of an issue, just in terms of control, because somebody else has to help him with it, and he likes being independent and things, but working on that. And then continuing to work on increasing communication. 1 year later, he's now walking and sometimes running. And actually, at this point, it's including long distances. We're at about 2 years now. He's much happier. He rarely has meltdowns. They're much shorter. Dad has not wound up injured from Matt in quite a while. He's now talking and laughing and joking and making and teasing people. He has friends. He goes out and sees them regularly. They come over and take him out to lunch because they like hanging out with Matt. Family's much less stressed. At this point, well, actually a year ago, but it's the same meds basically, his Depakote had gone from 4,000 down to 1,500. The Abilify had gone from 25 down to 5, and all the other meds were gone. They did add a scopolamine patch for decrease the saliva because of the swallowing issue, so having a lot of swallowing and saliva, that was causing problems. And his quality of life has improved drastically. Matt's dad, and we have this, we will hand it out to you, did a one-page profile for doctor's visits. Matt's dad, if any of you are medical professionals or not, wanted to make sure that people knew that you need to listen to Matt. And if Matt isn't in a position to let you know, you need to listen to his dad, because his dad does know him better than, second best to Matt. Matt has certain rules, and his rules are harder to break than your hospital's. As UCSF actually found out, because they got to pay for a new x-ray table because a tech wouldn't listen to Matt. Matt was insistent on wearing his socks. He didn't want to take his socks off to get an x-ray of his foot. You can take an x-ray through a sock. The tech didn't want to do that. Matt did thousands of dollars worth of damage to the x-ray table. And his dad kept going, "We told you." Matt will give you all the blood you want if you're in a lab. He will put his arm out, he'll let you tie it. You can do 10 minutes and 20 different vials. He's fine. If you try to take it in the hospital bed, he's not giving it to you. You're going to have a fight. And his dad would explain this. And the nurse who came in to do it, a phlebotomist, would be like, "No, our rule is we have to do it in your bed." And his dad was like, "Matt's rule is harder to break. Let's go to the lab." We have to be flexible. People have sensory issues. People have routines. People with disabilities especially learn that certain places mean certain behaviors or certain actions on my part and on your part. We have to listen to people. And we have to give people the respect, one, to an understanding that, yes, they in fact can tell us what they need, and 3, that we have to make some accommodations at times. His dad made this profile. He gives it out to the doctors and the hospitals anytime he has to go there. This has become such a routine. Matt's dad actually has authority from the hospital in their little tiny community. I think it's a 10-bed hospital. I mean, it's a tiny little hospital, to pretty much override anyone in the hospital other than like the, head honcho. And that's actually in the file, and anyone who has questions will call it's like, no, if Matt's dad's saying that this is how it needs to be done, this is how you're going to do it. And it's worked much better. Matt's out of the hospital. He's only gone, I think, once in the last year, which is huge. And again, he's walking, he's running, and no one's afraid he's dying anymore. His doctor came to a presentation we were doing in doctor training and made note of this, and shared that he and the psychiatrist had thought we were crazy, and that, these regional center people, but assured the audience, which was all doctors in the community, that in fact, regional center can be an ally. Regional center has resources. Regional center has nurses and doctors who can work with you, whether you're a parent or whether you're a professional. And that's true in all counties and all areas. Regional centers are divided up by county. Redwood Coast is the 4 counties along the coast. Very rural. We don't have a single town that hits 30,000 people in 4 counties. But San Francisco is Golden Gate Regional Center. Oakland is East Bay Regional Center. It's divided by counties. So whichever county you're in has a regional center. And again, whether you're professional or parents, it's a resource for you. So I think that's good. Yeah. Okay, so I think we're going to do panel and questions.
In the time before your patients meet you, how are they accomplishing early and accurate diagnosis? Who's referring them to you? And how are they demonstrating to you their ability to pay and honor your invoices?
Okay, so the initial diagnosis and things comes from the primary care doctor and or any specialists that have been referred to in the community. For paying for us, that is paid for by the regional center. The regional center pays for the team through what's called a purchase of service. So it's an individual contract assigned to that person. So for like Matt, the cost for Matt's TACT team went to Matt's account, if you will, and was purchased on his behalf. So those are guaranteed easily through the regional center. And the third part of your question, I'm sorry.
How are they referred? I think you answered their doctors.
The doctors refer them. Sometimes their social worker, service coordinator at the regional center refers them. Occasionally, some of the members on this team see them separately and refer them, nurses, et cetera.
I just want to also say that we do question diagnoses. Yeah. So somebody may come in with a diagnosis of XYZ, but the team may say, I'm not sure that that's actually the right diagnosis here, so, yeah.
And you have to remember that most of these people that would be served by regional center will be on disability, SSI, and have Medicaid, if not Medicare as well, benefits to pay for various services. One of the things that we do is suggest testing sometimes. Sometimes we'll say, for example, you saw it, the swallowing study. We'll say, this person needs these tests. These are medical tests that obviously cost money, sometimes a lot of money. A lot of these patients are people who will need sedation for a test, so makes the test even more expensive than it would have been. They'll have to come down to Stanford or CPMC or UCSF, coming down from Ukiah or Eureka for the test. So all of those are extra expenses. The regional center will pick up transportation expenses. The hospitals will bill their Medicaid, which in California is called Medi-Cal, their Medicare, whatever it is, just the way they would with anybody else.
As we study this, we study comprehensively. So some individuals that need to have anesthesia, for instance, general anesthesia, and they need dental work, often we'll try to encourage them to have the general anesthesia, the hospital dentistry, but get the other tests done as well. A chest x-ray, eye exam, ear exam, podiatry, anything of that nature. So make that general anesthesia episode productive so that you don't have to reproduce and add risk to their life.
I almost hesitate to make these remarks. They're going to seem tactless and maybe off-putting, but I really came here to have an overview or analysis in some depth of the various developmental syndromes, the genetics, the biochemical manifestations, the neurological manifestations, X-ray, inheritance factors, trauma at birth, medications. So why don't we start giving a diagnosis, the diagnosis of the cases that you cite? I mean, medicine starts with diagnosis.
Yeah. I apologize for that if I didn't make that complete. I did on Sally, the primary diagnosis is autism. The other two both had intellectual disabilities.
And maybe epilepsy did Boom have epilepsy?
Boom didn't have epilepsy, no.
Can't remember.
No, they were strictly intellectual disabilities on the other two as well. So, yes.
But many of the clients, and one of the reasons that I was asked to be on the team from the get-go was, I'm the neurologist, was that people with significant developmental, intellectual disabilities, which is defined as 30% reduction from average, I believe, in terms of cognitive ability, 30% or more reduction. If you take a look at that population, you're going to have something in the range of 25–30% of them will also have epileptic seizures. And if you take the people of that population who end up getting institutionalized, many of the clients that we see in the old days would have been institutionalized. The incidence of epilepsy goes up to 50 to 75%. So we have almost everyone that, a large percentage of the people that we see not only have intellectual disabilities, but they have epilepsy. They have known psychiatric diagnoses for various problems. We don't often make a new diagnosis of a specific chromosomal syndrome or genetic syndrome or a metabolic syndrome, although oftentimes we have suggestions that there may be a need for that kind of evaluation. And these days, those evaluations, as you know, can be pretty expensive. When you go to genetic testing, the standard now is called a chromosomal microarray, and we're up to, 3,000 or more to get one of those tests done. We're not necessarily in the TACT process doing a lot or even suggesting a lot of tests, although we often do want basic medical testing done, the kinds of things that should have been done, but because these are people who have significant intellectual disabilities, they often are not done, especially in a rural area.
Who generally makes the diagnosis?
The individual has been diagnosed. That's why they're a regional center client. But our team does look at how the diagnosis was made, and sometimes we'll actually recommend that they have genetic testing, or recommend that their workup was not complete. So we do look at that. But in general, we are not making the diagnosis of a developmental disability. They come to us with that diagnosis. And because they're already regional center clients. And just one second, I think when Lucy and I talk about the historical perspective in our session December 4th, we are going to talk a bit about the diagnosis of developmental disabilities from the pediatric perspective and then moving into transition into adulthood. So we will cover a bit of that in terms of some of the syndromes.
And there will be a session on genetic.
And there's going to be a session on genetic disorders and epilepsy with Dr. Lowenstein.
I think your comment really sort of highlights the team's task, really. There's an old saying that if you've seen one person with autism, you've seen one person with autism, because the fact of the diagnosis presents itself differently for every person. So we look beyond the diagnosis, we look at the symptomology, the behaviorism, and then we try to modify it for that diagnosis, because many of them are sort of a spectrum, if you will. So we might say Down syndrome is a trisomy, but it manifests itself differently in individuals and in different ages. So we look beyond the diagnosis and we look at what's happening to that person, both from their family standpoint as well as physiologic. So we try to dissect and take everything and look at everything independently and then sort of put it back together in a more sensible manner. So we're not looking at the diagnosis and say, for every patient that has this diagnosis, we will do this. But we look at that person and then we say, how does it manifest itself in this person and how can we improve their life? But, but the actual diagnosing part and the genetics part of it, that will be covered in the later future.
Yeah, well, it seems like a very valuable program. So maybe downstream we're going to have a little hard science here.
Yeah.
Can I just add on there a little bit? There are sort of clusters of diagnoses that often go together, you know, as we're talking about, you know, with autism, you know, autism spectrum disorders, 3/4 of kids have some degree of intellectual disability. Of kids with autism spectrum disorders, about 30% develop seizure disorders. Kids with autism spectrum disorders, between 1/4 and 1/2 also have ADHD. Anxiety is often part of the picture. In the general population, we know that about 1/4 of people have at some point a diagnosable psychiatric condition. In the subset of people with developmental disabilities, it's significantly higher than that. Mood disorders like bipolar disorder, in the general population, 1 or 2%. Ruth Ryan, her study looked at it in Colorado, about 8%. So certain things are certainly overrepresented. But again, part of our task is when somebody comes with a diagnosis of bipolar disorder, say, as we saw someone recently, on a truckload of medications and not doing well, gathering the history and realizing, no, actually, it turns out this person, with people who have known her for a dozen years, nobody had ever seen her have a manic episode. But boy, did she have a horrible history of abuse and trauma and really fit a classic picture of post-traumatic stress disorder, which would really significantly change the kind of management that she had been receiving up until that point. So yes, we do change the diagnoses or the impressions and communicate back with the local team to try to give a different perspective on what are we actually dealing with.
So, what's the integration with the school system and particularly the IEP process? Because so many of these kids, you know, are struggling with a developmental disability, but then the double whammy is the schools can't really adequately manage them. And I'm wondering if there's an integration between the school IEP system and your team, because I can imagine you would be incredibly valuable.
So the question is about the schools and the individualized education plan that all kids have. Pretty much every single child that we see through the regional center has an individualized education plan or IEP. We love it when the school psychologist, the school teacher, the special day class teacher, the speech and language therapist, the school-based therapist comes, and certainly that's a big part of what we try to do is get the big tent so that everybody is invested in seeing the child do better.
Well, and I think that gets to also the follow-up part, which we didn't actually cover on my being bad. But once the report is written, it goes to the person and their support team on the local level, along with the regional center. And then we coordinate typically monthly or bi-monthly meetings to start going through the recommendations, following up, holding people accountable for what they say they're going to do. And that includes schools, that includes families, that includes service providers, that includes the regional center. And so through that process with the recommendations and with the team meeting every month to really sit down and go, here are all the recommendations. What are we doing? What are you doing? Okay, next month you're going to come back and tell us what you did. Okay, what are you doing with the school, et cetera? It really integrates with the school. In fact, we've had quite a few referrals from the school district once they've been through the process a few times. So they've appreciated that support and that networking and that consistency in following up with the recommendations.
Yeah, final question.
I was just wondering if the TACT models kind of, do they have similar models in other regional centers that you know of, or the outcomes, or maybe some that you might want to show with your program, or some barriers to kind of having that more widespread?
Yeah, so the question is whether other regional centers have a similar program and what are some of the barriers that might be in terms of helping that spread, et cetera. Telemedicine is becoming more the norm, and teaming is becoming more the norm, which is great. We started it in part because we had the grants and some training from Ruth Ryan, et cetera, but in part because in our 4 counties, I mean, we had counties where there wasn't a neurologist or psychiatrist within literally 100 miles. Part of it was we had to figure out a way to get those resources, and telemedicine was one of the approaches we used. We did contact all the other regional centers several years ago to find out what they were doing. There are some of them that have smaller teams than we do, but they do have teams that will sit and meet, usually live because they're in a bigger community and everyone's sort of in that community, so they don't have to do it by video because there's not a 450-mile gap if we're doing Eureka. So some of the regional centers have done sort of similar projects. They've done them more recently. I don't know of any regional center or any project that's gone as long as we have on this. Actually, nor does Ruth Ryan on the telemedicine side of it, because we've talked to her about that. But I do know other regional centers have some.
Yeah.
I just one easy question. Are the RNs, LPNs, all these providers, all these people who provide day-to-day care to your patients, do they answer to the treatment center, or are they under your supervision?
No, they're in terms of the folks in the question was if the LVNs and nurses, who do they answer to in terms of following up and treatment? We make recommendations. We have no enforcement power per se, and we usually have a fair amount of cooperation with the doctors and the nurses and stuff in the community. Occasionally, they object, or they think we're crazy, but they'll try it anyway. So we get a variety of responses. For the most part, it's usually pretty good. And again, that follow-up, because then the family or the person and their support staff or whoever is going back to the doctor and back to the doctor. Our nurses who work for the regional center are willing to go with the person to their doctor's appointment with the person in the community and help explain, because they were part of the TACT, and help go through. They'll help summarize it. They'll come up with ways to make it as simple and as user-friendly as possible for the community doctors and medical professionals.
Well, thank you all for being here, and feel free to take a brochure on your way out. Oh, I'm sorry, Lucy has a question.
Hi,
This is Lucy Crane.
I'm Lucy Crane,
Snuck
and
in.
Jerry and I are partners in this endeavor. And thank you all for being here. This was just really a terrific presentation. And we have been asked to do a series of 6 sessions and to cover the spectrum of developmental disabilities. And this is something that, you know, in one case, a 3-foot chart doesn't cover. And so there will be issues which are covered in depth. There will be issues which are touched on. But one of the things, after having practiced for more than 40 years in pediatrics and developmental medicine and referring my patients to Jerry when they grew up, I have learned that making the diagnosis, no matter how complicated it is the easiest part of it. Helping to solve the issues for the individual and their family so that they can lead as normal a life as possible, no matter what the diagnosis is the more challenging thing. And I congratulate you all for doing that. Thank you.
Thank you very much, Lucy. Thank you. So we are done for tonight. I hope to see you all next week. Come up and take a brochure. And thank you so much for being here.